With this, we conclude with our inaugural session, and we immediately begin our webinar week. And I promise that it will be a very enlightening and enjoyable 6 days. It gives me immense pleasure to welcome and invite our first speaker, Dr. Neeraj Anand, who is Assistant Professor in our Department of Pediatrics, who will be starting with the first subspecialty of today, that is intensive care. He'll be talking about pediatric shock, early recognition and management. Over to Dr. Neeraj Anand.
Thank you very much, ma'am. A very good afternoon to respected VC sir, respected HOD ma'am, all the respected faculty members and dear residents. Today I will be discussing about shock in pediatric patients. So let's begin with. So we are going to discuss about pediatric shock, how to timely recognize shock in initial phase so that it does not go into a reversible phase, and how to manage.
Full screen.
Okay. And how to manage the patient of pediatric shock. Now coming on to the definition of shock. Shock is defined as an acute process characterized by body's ability to deliver adequate oxygen and to meet the metabolic demands of vital organs and tissues. Along with it, it is also there is an inefficient removal of byproducts of cellular metabolism. Now coming on to the different type of shock. On the basis of mechanism by which shock develops, shock is basically classified into 4 types. The first type is hypovolemic shock, which is basically due to loss of effective circulating blood volume, as seen in patient of diarrhea and vomiting, and in patients of dengue where there is third space loss, or in case of burn. So hypovolemic shock could be seen in these patients. Cardiogenic shock, the basic mechanism which is present in cardiogenic shock is basically cardiac pump failure. It is seen in patients of congenital heart disease or patients of viral myocarditis or in patients of cardiomyopathy. Obstructive shock is basically due to mechanical obstruction to heart outflow, or if there is any restriction of cardiac chambers, such as seen in cases of tension pneumothorax or pericardial effusion, cardiac tamponade, or pulmonary thrombosis. The 4th type of shock is distributive shock, which is basically due to abnormal vasomotor tone. There is abnormal vasodilatation which leads to venous pooling of blood. It is seen especially in case of neurogenic shock. It could be seen in case of further classified into neurogenic, anaphylactic and septic shock. Neurogenic shock is seen in patients of head trauma, in spinal cord trauma or brain trauma. In anaphylactic shock, there will be associated features of anaphylaxis. Septic shock usually is a combination of different type of shock. The septic shock patient may have hypovolemia due to third space losses, or the patient of septic shock may have cardiogenic shock features due to myocarditis, or these patients may also have features of distributive shock due to abnormal vasodilatation. Now, to compensate for these fluid loss, there is compensatory mechanism to maintain blood pressure. It could be done by either increasing the heart rate, because cardiac output is a product of stroke volume and heart rate. So to maintain the blood pressure and cardiac output, the heart rate is increased, which leads to tachycardia, and also there is redistribution of blood from less vital organs such as skin as well as GI tract to more vital organs such as CNS as well as heart. So there is increase in systemic vascular resistance, and this presents as cold, clammy skin. There is also increased oxygen extraction, which is manifested as low central venous oxygen saturation. There is redistribution of blood to brain, heart, and kidney. To compensate for metabolic acidosis, which is developed as a result of anaerobic metabolism, there is respiratory compensation. So the patient present with tachypnea. The tachypnea could be with increased work of breathing or without increased work of breathing, depending on type of shock. In renal compensatory response, to compensate for metabolic acidosis, there will be increased excretion of hydrogen ions and retention of bicarbonate. And as a stress response, there will be synthesis and release of cortisols and catecholamine and ADS secretion. Now, in all type of shocks, the shock progresses through these three stages: compensated stage of shock, decompensated stage, and irreversible shock. In case of compensated shock, the blood pressure remains normal as the compensatory mechanisms such as increase in heart rate and redistribution of blood are able to deliver adequate oxygen and fluid and metabolic demands are met in compensated phase. So the blood pressure remains normal in case of compensated shock. In case of decompensated shock, the compensatory mechanisms such as tachycardia, tachypnea, these all fail. Redistribution of blood, these all fail. So ultimately the patient land up into decompensated shock and there is fall in blood pressure and the patient is hypotensive. If the patient is not managed properly at this stage, the patient may ultimately land up into multi-organ dysfunction and an irreversible stage of shock, which ultimately leads to death of the patient. Now, how do we assess a patient of shock? If any patient comes with signs of impaired perfusion, we ask the attendants about the history of trauma. If there is any history of trauma, then we suspect for hemorrhagic shock, or the patient might have obstructive shock due to tension pneumothorax or cardiac tamponade, or the patient may have neurogenic shock, which is either could be due to spinal trauma. If there is no history of trauma, then we ask for the history of fever, rash, and any septic focus, whether the patient is having UTI or pneumonia. If the answer to these questions is yes, that means we would suspect the patient might be in septic shock. If the answer to these questions is no, then we will look for any history of fluid loss. The patient might have diarrhea, vomiting, or the patient might have polyuria as seen in case of DK patients. The burn patient may have insensible water loss. So these patients may ultimately, if there is history of these fluid loss or gastroenteritis or polyuria or burns, that means the patient might be in hypovolemic shock. If the answer to these questions is also no, then we look for we go for cardiac examination. If the cardiac examination is abnormal, then we ask about history of any congenital heart disease, and we examine for any muffled heart sound. And if the answer to this is yes, that means the patient might be in cardiogenic shock. If the answer is no, then we look for any exposure to allergen. If there is any exposure to allergen, that means the patient might be in anaphylactic shock. Now then we'll look for clinical manifestation of shock. There are few clinical manifestations which are common to all type of shock. Tachycardia is a non-specific feature of shock and one of the earliest marker of shock. So tachycardia with weak and thready pulse means the patient is in shock. Tachypnea. In tachypnea, we have to see whether the patient is having tachypnea with increased work of breathing or without increased work of breathing. Tachypnea without increased work of breathing, that is quiet tachypnea, is seen in patient of hypovolemic shock or distributive shock, whereas increased work of breathing with tachypnea is seen in patients of cardiogenic shock due to pulmonary edema, or it could be also present in case of tension pneumothorax, or if the patient is of septic shock with ARDS, then in these patients there will be tachypnea will be associated with increased work of breathing. Then we look for decreased urine output. Decreased urine output, which is basically a marker of decreased internal organ perfusion. So it also represents that the patient might be in shock. We look for signs and symptoms of poor peripheral perfusion. That is, we look for capillary refill time. Capillary refill time will be delayed in case of cold shock. In case of warm shock, capillary refill time will be less than 1 second. That is known as flash capillary refill. We also look for any signs of respiratory distress or failure. It could be present in patient of pneumonia, tension pneumothorax, ARDS. Then we look for altered mental status, and altered mental status shows that the cerebral perfusion is hampered. Low blood pressure, the patient of shock may have hypotension or may not have hypotension. Low BP is not actually required to classify a patient into shock. Jaundice, which shows that the patient is having multi-organ dysfunction and liver is also involved due to congestive, or it could be involved in congestive hepatomegaly. Now, how do we differentiate between different type of shock? We could differentiate on the basis of history. Hypovolemic shock will have history of GI losses and hemorrhage. Distributive shock patient will have history of anaphylaxis or will have any septic focus. Or neurogenic shock will have history of trauma. Cardiogenic shock will have history of any myocarditis. There will be tachycardia with decreased ejection fraction. Cardiomyopathy, the patient will be having a history of congenital heart disease. In sepsis may have encompass different type of shock together. Obstructive shock patient might present with cardiac tamponade or tension pneumothorax. So to differentiate between these type of shock, hypovolemic and distributive shock patient will present with quiet tachypnea, whereas the patient of cardiogenic shock will have tachypnea along with increased work of breathing. Hypovolemic shock patient will have normal pulse pressure, whereas the patient of distributive shock, especially the patient with warm shock, will have wide pulse pressure with bounding peripheral pulses. In cardiogenic shock, the patient will have narrow pulse pressure. Hypovolemic shock patient will have delayed capillary, all type of shock will have delayed capillary refill time except for warm type of distributive shock, in which there will be capillary refill time will be reduced than less than 1 second, known as flash capillary refill. There will be cold extremities seen in case of hypovolemic as well as cardiogenic shock, whereas in warm type of distributive shock, there will be warm and flushed extremities. There will be favorable response to fluid in case of hypovolemic shock as well as distributive shock, whereas adverse response to fluid challenge will be seen in case of cardiogenic shock. So we have to give fluid judiciously in case of cardiogenic shock. Now coming on to the changes, what changes we see in preload, afterload and cardiac conductivity in different type of shock. In hypovolemic shock, the basic pathology is decreased preload due to decreased circulating blood volume. So there is decreased preload, and in compensatory response, there is increase in systemic vascular resistance, which leads to increase in afterload of the patient. Due to decreased skin perfusion, there is increase in capillary refill time more than 3 seconds and increased oxygen extraction at the tissue level, which leads to low mixed venous saturation. In cardiogenic shock, the basic pathology is basically decreased cardiac contractility, which leads to increase in preload as end diastolic volume is increased, and also there is increase in afterload due to increase in systemic vascular resistance. Capillary refill time is again increased and mixed venous saturation is low. In case of distributive shock, the basic mechanism is abnormal vasomotor tone, which leads to abnormal vasodilatation and venous pooling of blood. So there is decrease in afterload due to abnormal vasodilatation and decreased in preload. Capillary refill time is initially decreased due to, especially in warm type of distributive shock, and mixed venous saturation is high due to venous pooling at the tissue level. In obstructive shock, there is mechanical obstruction to cardiac. So there is decrease in cardiac contractility in case of obstructive shock. Preload will be increased, afterload is also increased, capillary fill time will be increased, and mixed venous saturation is low. Now, how to recognize the severity of shock? In the early compensated stage, the patient will be restless, anxious, and irritable, whereas in late and advanced stages, decompensated stage, the patient will be listless, apathy. The patient may ultimately land up into unconscious state. There could be confusion, incoherent, slurred speech due to decreased cerebral perfusion. DTR may be absent, or reflexes will be decreased or absent. There will be dilated pupils which are slow to react. In early compensated phase, the heart rate will be slightly increased, whereas in late signs, there will be significant tachycardia with slow, irregular, weak, thready pulse. In early stages, there will be pale and cold skin, whereas in late stages, there will be significant cold, clammy, pale skin with increased toe to core temperature gap. There will be slightly increased respiratory rate in initial phases, whereas in later on decompensated phase, there will be significant irregular, significant rapid breathing with slow, shallow respiration. Now coming on to the management, the general goals for management of shock includes the goal is to increase oxygen delivery and to decrease oxygen demand. So for all children, we start with 100% oxygen. We give fluid boluses as per requirement. We have to manage both hypo as well as hyperthermia, because hyperthermia ultimately leads to increased oxygen demand. We have to correct any metabolic abnormalities, correct any electrolyte abnormalities. We have to maintain blood glucose level below 180 milligram per deciliter. We also have to avoid hypoglycemia. Depending on suspected cause, if we are suspecting septic shock, then we have to start antibiotics within 1 hour. If the patient is not responding to fluid alone, we have to start inotropes. Mechanical ventilation helps by decreasing work of breathing as well as redistribution of blood to more vital organs. Then we start, as in any emergency patient, we start with airway, breathing and circulation. In airway, if the patient is unconscious, then and GCS is below 8, we have to intubate the patient. In breathing, we start with 100% oxygen and titrate oxygen as per the saturation. In circulation, we have to establish IV access rapidly, and if not possible, especially in case of shock, the patient is having weak and thready pulses, or the pulses may be collapsed, veins may be collapsed. In that case, we might have to go for intraosseous cannulation. So if we could not get IV access within 90 seconds, we should go for intraosseous access directly. We have to monitor for response by looking for capillary refill time and frequent BP monitoring. In initial laboratory findings, we have to send ABG of the patient to look for metabolic acidosis, to look for any hypoxia, hypercarbia. We could look for lactate, serial lactate monitoring could be done to look for improvement in perfusion of the patient. We have to look for blood sugar. We have to avoid both hypo as well as hyperglycemia. We have to correct any electrolyte abnormalities. CBC has to be done to look for any abnormal anemia or any thrombocytopenia, PTA, PTT. Blood type and cross matching if we are planning for any blood transfusion. Cultures, especially in patients of septic shock, we have to send urine cultures, blood cultures and other cultures as required. In fluid management of shock, we have to replace both deficit fluid as well as maintenance fluid. The deficit fluid is defined as a fluid lost prior to the medical care, and it could be replaced either by crystallite fluids or colloid fluids. The preferred is crystallite fluid as it is readily available and also it is less expensive. Ringer lactate Normal saline or half normal saline could be used as a crystalloid fluid. Colloid fluid could be either albumin, dextron, and diastarch. Maintenance fluid is to be given to replace any insensible water loss. Holiday-Sanger method we already know. Now, how do we give fluid in different type of shock? In patient of hypovolemic shock, we give initial boluses of 20 ml per kg of fluid, which is to be given over 5 to 10 minutes and to be repeated as necessary. The amount of fluid that is to be given depends on whether we have ICU care available or not. That will be discussed in later slides. If the patient is presenting with significant severe dehydration, in that case, we have to give 100 ml per kg of fluid as per IMNCI guidelines. This 100 ml per kg of fluid is further divided into 30 and 70 ml per kg. In the initial 30 ml per kg of in child less than 1 year of age, the initial 30 ml per kg of fluid is to be given in 1 hour, and the next 70 ml per kg of fluid is to be given in next 5 hours. Whereas child more than 1 year, we have to give initial 30 ml per kg of fluid in within 30 minutes, and next 70 ml per kg of fluid is to be given in next 5 hours, next 2.5 hours. If the patient is presenting with hemorrhage, we have to replace blood. If blood is not readily available, we could give fluid. 3 ml of fluid is to be given per ml of blood loss. Albumin can be given as a plasma expander, especially in patient of trauma and burn. In patients of cardiogenic shock, we have to look for any signs of fluid overload. The signs of fluid overload could be either raised JVP, congestive hepatomegaly, bilateral pedal ligma, and bilateral basal clefts. So if these signs are present, we start with diuretics and vasodilators. If there is no signs of fluid overload and the patient is having signs of fluid depletion, then we could give small aliquots of fluid 5 to 10 ml per kg of fluid in 10 to 20 minutes according to need. In obstructive shock such as cardiac tamponade or tension pneumothorax, we have to correct the cause of shock. So if the patient is having tension pneumothorax, we need to do needle decompression and ICD in patient of tension pneumothorax. In case of cardiac tamponade, we need to do pericardiocentesis. A patient of shock, especially of septic shock, may have more than one type of shock, as already explained. Distributive shock, it could be either septic shock, anaphylactic shock, or neurogenic shock. So septic shock patient, in case of septic shock that we will discuss later in detail. In anaphylactic shock, the drug of choice is adrenaline, which is to be given IM, and fluid as per requirement of the patient. In case of neurogenic shock, we give fluid boluses of 20 ml per kg over 5 to 10 minutes. In pediatric patient, special consideration is to be given in patient of severe acute malnutrition. So in every patient of every pediatric patient, we should look whether the patient is in severe acute malnutrition or not, because in severe acute malnutrition, we do not give fluid boluses. We avoid fluid boluses in severe acute malnutrition, and we give 15 ml per kg of fluid over 1 hour under monitoring. We monitor for heart rate as well as respiratory rate. If the heart rate is rising by more than 15 and respiratory rate is increasing by more than 5 per minute, that means the patient is deteriorating with fluid bolus and we have to stop fluid bolus. But if there is improvement in respiratory rate and heart rate, then we could give additional bolus as per requirement. The fluid of choice in case of severe acute malnutrition is either Ringer lactate with 5% dextrose or 0.45% normal saline with 5% dextrose. Now the amount of fluid that could be given in patient of shock depend on whether we have ICU care available or we do not have ICU care available. So if we have ICU care available and we could monitor for any fluid overload, then in that case we could give fluid boluses up to 40 to 60 ml per kg with 10 to 20 ml per kg of per bolus of fluid over the initial 1 hour. But if we do not have ICU care available with us and the patient is not hypotensive, then we should avoid fluid boluses. But if the patient is presenting with hypotension, in that case we should give fluid bolus of 10 to 20 ml per kg per bolus, and we could give fluid only up to 40 ml per kg over the initial first hour. Now, what are the monitoring goals we have to achieve according to the American Academy of Pediatrics? We have to look for quality of both central and peripheral pulses. Both central and peripheral pulses should be strong. Distal pulses should be equal to the central pulses. Peripheral skin perfusion, we have to look for peripheral skin perfusion. The periphery should be warm. Capillary refill time should be less than 2 seconds. Mental status of the patient should be normal. Urine output should be more than 1 ml per kg per hour. And the blood pressure should be above the 5th centile for that age. So the 5th centile for different age include for neonate up to 28 days, the cutoff is 60 millimeter of mercury. For 1 month to 1 year, the cutoff is 70 millimeter of mercury. For age of 1 year to 10 years, the cutoff systolic blood pressure is 70 plus 2 into age in years. And for more than 10 years, the cutoff is 90 millimeter of mercury. Now, subsequent ICU goals that has to be achieved include the patient serum lactate should be normal, less than 2 millimole per liter. Target mean arterial pressure should be achieved. We have to restore and maintain normal perfusion pressure, which is defined as mean arterial pressure minus the central venous pressure for that age. Central venous oxygen saturation should be greater than 70%. And the cardiac index, which is equal to cardiac output divided by body surface area, it should be greater than 3.3 and should be less than 6 liters per minute per meter square. Now coming on to the septic shock management algorithm. So as the patient arrive in the emergency department, we should recognize any signs of decreased mental status, and we should look for signs of decreased perfusion. We start with high flow oxygen at 100% FiO2 and establish IV and IO access according to pulse. Within 5 minutes, we have to give initial 20 ml per kg of isotonic saline bolus if there is no hepatomegaly, no rails, or there is no signs of any fluid overload. Fluid boluses of 20 ml per kg could be repeated up to 60 ml per kg or until the perfusion improves. If there is any signs of fluid overload, such as there is rails, crackles, or there is congestive hepatomegaly, then we should stop any fluid bolus. We have to correct hypoglycemia as well as hypocalcemia. We should begin antibiotic within 1 hour. If the patient is not responding to fluid after that, then we should start IV or intraosseous inotrope infusion. The preferred inotrope is epinephrine, and the preferred dose for initially we start with 0.05 to 0.3 microgram per kg per minute and titrate according to the need. If there is need for any central venous access or airway access, we should use atropine or ketamine. We have to titrate epinephrine depending on requirement. If epinephrine is not available, then we could use dopamine. If there is if the patient is having features of warm shock, that is, the patient is having wide pulse pressure with peripheral pulses, then we should use norepinephrine instead of epinephrine. If the patient is not responding to these also, then we should consider for absolute adrenal insufficiency, and we should consider hydrocortisone. The dose of hydrocortisone is 50 to 100 milligram per meter square per kg per meter square stat, followed by 50 milligram per meter square per day, to be divided into 4 to 6 hourly doses. Now, once we have given epinephrine and the patient is not responding, then we should look whether the patient is having normal BP and whether the patient is having cold shock or warm shock. If the patient is having normal blood pressure with cold shock and central venous oxygen saturation is below 70% and hemoglobin is more than 10 gram per deciliter, then we should start with milrinone infusion. Milrinone is a good inotrope as well as has vasodilator effect. So it increases stroke volume as well as it causes vasodilatation, so it decreases afterload also. We could also add nitrosovasodilators because they decreases systemic vascular resistance. So nitrosovasodilators could be used in patients with high SVRI and poor skin perfusion. If the patient is still not responding, we could consider for levosimendan if unsuccessful. In patients of cold shock and with hypotension and the central venous oxygen saturation is less than 70%, we should start norepinephrine along with epinephrine to attain normal diastolic blood pressure. Norepinephrine is a potent vasoconstrictor, so it causes redistribution of blood from skin and GI tract to more vital organs and maintains diastolic blood pressure. If cardiac index is still below 3.3 liter per minute per meter square, then we should add dobutamine or levosimendan or milrinone. If the patient is presenting with warm shock with low blood pressure and is already on norepinephrine and not responding to norepinephrine alone, then we should consider for adding vasopressin, terlipressin or angiotensin. But if cardiac index is less than 3.3 liter per meter square, we could add epinephrine, dobutamine or levosimendan. If the patient is still having persistent catecholamine resistant shock, then we should evaluate for any pericardial effusion or pneumothorax. We could also go for ECMO in case of refractory shock. Steroid we have already discussed. If the patient is not responding to catecholamines also, then we should consider for stress dose corticosteroid. Blood products, we should transfuse PRBC if the hemoglobin of the patient is below 7 gram per deciliter. FFP is to be given if the patient is having deranged coagulation profile and is associated with active bleeding, and or if we are planning for any surgical procedure and there is deranged coagulation profile. Prophylactic platelet transfusion is to be given only if the platelet count is below 10,000. Platelet transfusion could be given below 20,000 if there is significant risk of bleeding. Platelet has to be transfused if there is any active bleedings or we are planning for any surgery or invasive procedure. So we have to maintain the platelet count above 50,000 in these patients. Blood glucose level should be maintained below 180 milligram per deciliter, but we should also avoid any hypoglycemia. Antibiotics has to be started within 1 hour. And once we have reverse fluid, once the patient shock has been resolved, we should look for any signs of fluid overload. If there is any signs of fluid overload, we could use diuretics to reverse this fluid overload. Deep vein prophylaxis is not routinely recommended in these patients. We have to give prophylaxis to prevent stress ulcers in patients of shock. We should start early enteral nutrition as soon as the patient is stabilized, even if the patient is on vasopressors. Now, coming on to the inotrope, a few slides about inotrope. I think time is over.
Dr. Neeraj, you can continue.
Okay. So we are going to discuss about few inotropes that are routinely used in PICU settings in patients of shock. Adrenaline, which is used in all patients, which is preferred agent in cold shock. Adrenaline acts by acting on all adrenergic receptors, whether alpha receptors or beta receptors, at low doses, that is at dose 0.05 to 0.3 microgram per kg per minute. It is a good inotropic agent. It causes inotropy, that is, it increases force of contraction, leading to increase in stroke volume. It causes chronotropy, that is, it increases heart rate, so ultimately leading to increase in cardiac output. And it also causes vasodilatation, leading to decrease in afterload. So all these beneficial effects lead to increased systolic blood pressure. Diastolic blood pressure is decreased or could remain normal. Cardiac output will increase, but at higher doses, more than 0.3 microgram per kg per minute, although there is increase in blood pressure, but it is but the patient is will be having increase in myocardial oxygen demand. So it is not preferred to use higher doses of adrenaline.
इन्होंने मुझे ग्रुप में ही नहीं ऐड किया था सैटरडे.
How to start? Now we are going to discuss how to start and titrate adrenaline. We start at a lower dose of 0.1 to 0.3 microgram per kg per minute and titrate to target minimal mean arterial pressure. If the blood pressure of the patient improves, but perfusion worsens, that means the patient's myocardial oxygen demand is increased at higher doses. Actually, adrenaline causes vasoconstriction also. So the perfusion might increase at higher doses of adrenaline. So in that case, we should add iododilators such as dobutamine or milrinone.
इसमें ये उल्ला है कि 90.
Noradrenaline is basically a pressure agent which causes intense vasoconstriction. So due to intense vasoconstriction, it causes increase in systemic vascular resistance, leading to redistribution of blood from peripheries to more vital organs, CNS as well as heart. So it increases both systolic blood pressure as well as diastolic blood pressure. It also has positive inotropic effect, that is, it causes increase in myocardial contractility also. It is particularly useful in distributive shock, warm type of distributive shock. Now coming on to the dopamine. Dopamine is given if we do not have adrenaline available with us. Dopamine binds with dopaminergic as well as adrenergic receptors. At lower doses, dopamine bind causes increased contractility as well as vasodilatation in renal as well as mesenteric bed, which is not a very significant effect for shock. We use doses more than 5 microgram per kg per minute in patients of shock. At doses 5 to 15 microgram per kg per minute, the beta 1 effect predominates, which ultimately leads to increased cardiac contractility.
Dr. Neeraj, please try to conclude in 2 to 3 minutes so that we could take questions also. Okay. Thank you.
So due to increased cardiac contractility as well as increased heart rate, there will be increase in cardiac output. There will be increase in systolic blood pressure, which are beneficial for the patient of shock. Although the dose mentioned for dopamine could be used from 5 to 20 microgram per kg per minute, but the dose above 15 microgram per kg per minute should be avoided, because at higher doses the alpha effect predominates, which leads to vasoconstriction. So there is disproportionate vasoconstriction, and also there is increased myocardial oxygen demand. This may also lead to arrhythmia and tachycardia. So the preferred dose is usually 5 to 15 microgram per kg per minute. Dobutamine acts basically on beta 1 receptors. So due to effect over beta 1 receptor, it increases cardiac contractility, leading to increased stroke volume, which ultimately leads to increase in cardiac output. It is a good choice, especially in situations with poor perfusion with high systemic vascular resistance due to vasoconstriction. So dobutamine may be administered or added to vasopressors in presence of myocardial dysfunction.
We can conclude in 1 or 2 minutes.
Okay.
Yeah.
So what are the clinical signs that we have to monitor in the patient of shock? We have to look for pulses, capillary refill time, state of hydration, any signs of fluid overload such as hepatomegaly, JVP. We have to look for urine output. In biochemical markers, we have to look for hypohyperglycemia, any electrolyte abnormalities, we have to look for any multi-organ dysfunction, signs of multi-organ dysfunction, that is urinary or blood urea nitrogen and creatinine. Thank you. That's all from my side.
Thank you so much, Dr. Neeraj, for such an excellent presentation and making such a complicated topic simple to understand. Now, I would like the audience, if they have any questions, they can ask us. They can write in the chat box, and Dr. Neeraj will be happy to answer.
In the meantime, we can request Dr. Siddharth to load his presentation. This one not